Uh, Welcome everyone to this webinar of the Lancet Citizens Commission on reimagining India's health system. Um, the commission is an ambitious cross-sectoral endeavor that aims to lay out a citizens' roadmap to achieving universal health coverage for the people of India. It will be a comprehensive research effort that also that brings together key stakeholders across the social spectrum. The Commission's monthly webinar series serves as a platform for public health discourse in India and a means for academics, practitioners, and public to engage on substantive and timely issues regarding universal health coverage in India. Today's webinar is being co-hosted by Population Foundation of India and by ARTPARK, which is the AI and Robotics Technology Park at the Indian Institute of Science, where I serve as an advisor. The launch of the National Digital Health Mission in 2017 was an important milestone for India, and now called the Ayushman Bharat Digital Mission, ABDM. Its aim is to develop the backbone necessary to support the integrated digital health infrastructure of the country. It will bridge the existing gap among different stakeholders of the health ecosystem through digital highways. Today's panel will focus on understanding the scope of ABDM, its mission, components, and plans, as well as the challenges in operationalizing it. In some sense, we will address the why of ABDM, right? And how ABDM should, in fact, achieve, improved healthcare in the country. There will be a short survey at the end of the webinar. Please do fill it out and let us know your thoughts and suggestions about the topic and future webinars you would like to see. Finally, you can sign up on the website to receive the Commission newsletter, alerts for future webinars and other events. Now I'd like to introduce you to our esteemed panelists. Kiran Anandampillai. Kiran is a technical advisor at the National Health Authority of the National Digital Health Mission and Ayushman Bharat. He's a telecom engineer and a founding member of OnMobile, a company that was spun out of Infosys, helped to build OnMobile from a 10-person to a 1,200-person company, and with substantial revenues. He has since moved on to work on projects that deliver social impact. He was a volunteer for technology at UIDAI till August 2012 and has co-founded Drishti, a social impact eye care chain that provides affordable eye care in underserved markets in Karnataka in India. And his passion comes from the belief that setting up the right technology building blocks can help India leapfrog into universal healthcare delivery of it. Dr. Sharad Iyengar has worked for several years with the United Nations in India and abroad. He currently serves as the Chief Executive of ARTH Society in Udaipur. ARTH is a public health organization pursuing research, training, program support, and advocacy initiatives in the field of sexual and reproductive health, neonatal and child health, and health systems and policy. The organization has a field service and community mobilization program in southern Rajasthan, and works with the state and central governments by contributing to the National Rural Health Mission. And as our third panelist, we have Sharad Sharma, who co-chairs the technology work stream of the Lancet Citizens Commission along with me. And he has 3 decades of experience in the internet, enterprise software, digital finance, and digital health sectors, and is a prominent voice in India's technology ecosystem. He co-founded iSpirit Foundation, a non-profit technology think tank devoted to making India a product nation. Earlier, he chaired NASSCOM Product Forum in its formative years and was a member of the NASSCOM Executive Council from 2009 to 2013. Sharad is an active technology angel investor with a whole slew of companies he mentors. He was also instrumental in the success of India's first IP-focused fund, India Innovation Fund, and he's a member of SEBI's Financial and Regulatory Technology Committee, and has also served on RBI's UK SINA MSME Committee and National Digital Payments Committees. So we have, as I said at the outset, a very distinguished panel, and what we will do now is to request Kiran Anandam Pillai to give us a presentation that will introduce the Ayushman Bharat Digital Mission in some detail to all of us, and then we will follow that up with a panel discussion. And as always, please do post your questions, and those will be monitored, and we will get to discussion period during which some of the questions at least can be brought up to the panelists. So with that, perhaps I can request Kiran to give us his presentation. Thank you.
Thank you. Thank you so much, Vijay. And it's a really big pleasure to be here talking to the group at Lancet. I think also very important, I think, for overall this ecosystem to understand where Ayushman Bharat Digital Mission is going and how some of these new...
Kiran, you've muted yourself.
I'm so sorry.
Yeah.
Apologies. So thank you so much, Vijay. I was just saying that it's really a pleasure to be here speaking on to this group. I think it's quite important for this group to have a sense of what is Ayushman Bharat Digital Mission and probably how it can actually, how they can visualize components that are coming out of this to be useful in their own work. Would love to hear more about that during the interactive session. I'll be very brief. Most of you already know this, that this mission actually started as a pilot back in 2020, August 2020, right at the start of the pandemic. It's implemented by the National Health Authority and recently went national. And its objective is to build what we call as building blocks. But the question is, what are these building blocks? And the easiest way to understand it is to think of that the mission is going to build new digital public goods in 3 key areas. The first area is to do with health data. And essentially this looks at the problem of how do we create interoperable health data, but not just interoperable personal health data, but how can we also do it for public health data as well as data for anonymized and large machine learning kind of data sets. The second problem it looks at is how can we actually make the process between payers and providers more seamless, and through something called Health Claims Exchange or HCX. And this is going to be quite key as we go towards UHC, because we need to bring the cost of care down and essentially be able to include OPD kind of claims in the architecture, and that very little of that happens in India today. And the last one is to bring interoperability into digital health services. And this could be things like teleconsultation or being able to find an ambulance. And these are the three big digital public goods that ABDM built. So what we'll do is spend the next 30 to 40 minutes to understand each of this in a little bit of depth, and then we can actually get into one. So I'll start with the personal health records area. Now, when we think of personal health records, and it's very important that we continue or view this in the construct of user-controlled health information. And we'll talk about why that's important given India's direction of privacy laws and how things are going. But if you think about what do people actually value with their health information, today the only thing they'll tell you is, hey, I went to a health facility. If after I went to that health facility, if I can just see that on my phone, that's value for me because I can be able to get my, say, prescription or my X-ray on my device. It will take a certain amount of education and time before people realize that whichever health institution they go to, they can actually collect it using the same app. And it will take a little more time before the sharing as a practice comes, saying, hey, I have all my health information in one place. Why can't I share this with my doctor? And so on. So we think that there is going to be a learning curve for consumers to understand PHR, and that's kind of the value that we are. So we are focused a lot on making sure that the first experience, that the fact that when you go to a health institution, come out, you can just get hold of that record working seamlessly as the very first step in this journey. Now, we know today that when you look at health providers across India, they're already going digital. I mean, if you had a COVID test in the last year, you probably got an SMS on your phone, you went to some lab's website, you put some code and you actually saw your COVID test report as a PDF on your phone. But the challenge with this is, this did not really get added to your long-term record, and you are likely to have lost it by now already. And two, the format in which this got shared was a PDF, which is nice because you can, as a human, interpret it, but this is not great for machines because this is not standardized in a machine readable format. So it really can't be added too much into too much analytics. Now, this is exactly what ABDM is trying to change. So what it says is, hey, Mr. Healthcare Provider, if you're creating a health record digitally already, don't just share it through this link or a SMS that you're doing. Can you also link it with something we call as a PHR address? And two, when you share it, can you instead start using a standardized format? And we use FHIR as the standardized format for all of the health information that gets shared. Can you start sharing it in an FHIR based format? And that's the really two shifts that we are trying to get from every healthcare provider who creates any health information in the country, right? Now, we are also kind of restricting in the beginning what health information can be shared and linked. So we have identified about 6 types of health records that ideally should be linked with your PHR. And we think the lowest hanging fruit is likely to be diagnostic reports. We already know that a bulk of the diagnostic reports in India are already in digital form. So can we make sure that every diagnostic report actually gets access? There's going to be a lot of benefits to this because one of the things that we foresee is now full DICOM images can actually be linked. You can actually have, you have small doctors who send patients to diagnostic labs nearby. They can actually get access to the whole information and not just the radiologist summary that they get back today. Similarly, discharge summaries and OP consultation notes we think will be next, but there is going to be a behavior shift required before prescriptions and things that are today mostly on paper, done in paper, come into play. And that we think will really come over time. So immunization records are the last bit, starting with the COVID information. So these are the types of health records that can actually be linked with a PHR address today. Now, what is a PHR or an ABHA address? So this is basically just like you have an email ID. Think of this as an identifier that you as a user have to get if you want to collect health records digitally. So it's really up to you to create it, and all you need is just your name, year of birth, gender, and a mobile number to create such a thing. It looks like, in my case, it looks like Kiran MA at ABDM. So it's a user chosen name at a domain, as we call it, which is a health information exchange domain. And essentially with this, you can now start collecting what we call as your health information. And these are actually links that you collect. And it's designed so that you can actually opt out at any time. So we think there is as part of how we've been thinking about the consent and about privacy in the whole system, we think users need to have the power to say, okay, I'm in, and if they feel at some point that they want to opt out, they should be able to do it. And also the system enables for information sharing to be completely consent driven. And we'll talk about it more as we kind of go on. But also importantly, we are trying to design this not just for people with smartphones. So a lot of the talk that I will do today will focus really on experience for people with smartphones. But I also want to share that the architecture is actually designed for also people who carry almost absolutely no phones or just carry feature phones. And I'll touch upon that in a bit, and we can actually take up certain questions related to that as we get into the Q&A level. Now, how do you actually get your PHR address or your ABHA address? It's pretty simple. You guys can try it while we are on this call. You can go to phr.abdm.gov.in, or you can use any of these apps that have already qualified to issue them. You can use the Arogya Setu app, or the Paytm has a mini app for health now, Eka Care and others, to actually create your ABHA address. Or like I was sharing, if you do not even have a phone, or you are somebody who's typically largely serviced through a government program, you can create it using your Aadhaar and something we call as ABHA. But that will require a biometric authentication and a KYC before you're issued, and then your address will therefore not be user chosen, but it will look like a 14-digit number at ABDM in that scenario. But that can also be used to link records, and people are actually issued a physical card when they're typically given an assisted registration. So when you have a user self-registration process, all you see is a little QR code on your phone. But if you have an assisted registration, you will walk away with probably a little card that you can then show at healthcare facilities. Now, how exactly does this work to create records? Now, we know that whenever a health record is created, it's typically created in a piece of software. Usually this software is called health information management software, or a EMR software, or a lab information management software. Usually it is hosted, either cloud hosted, or sometimes it's on premise at these health facilities. And as we shared earlier, what we expect is whenever a new health record is created, we expect that to be linked with your PHR address. Now, where do you link it? You link it with actually one of the first digital public goods that we're talking about. This digital public good is called the Health Information Exchange and Consent Manager. And there is one that the National Health Authority has built and operates for ABDM. And of course, in the future, we expect there will be multiple of these from many players. But all facilities, and whether it's a health program of the government, whether it's a small clinic, whether it's a hospital, are all expected to just put a link. So if you look at inside a PHR address, all you see is a bunch of links saying, hey, here are where your health records that are being held. Now, let's say you have a user generated health record. Let's say I have a Fitbit data, or I have a little piece of prescription with me. You can actually add that to your health record, but you need to use a PHR app and you need to scan it. And then the PHR app will link it to your PHR record. So let's get a bit into how this thing works. We call this a federated architecture because there isn't really a central repository. The government or any entity is not holding a central repository of health records. The records are similar to what happens on paper today. It is at the facility that created it. The doctor or the facility that created it has a copy, and you as a patient can have a copy. There's nobody else who has a copy unless you agree to share a copy with someone else. So that's the first part of the architecture. So facilities are expected to hold on to it, and they do this activity of linking by simply choosing the software. So they're already using the software today. We expect them to migrate or get their software upgraded to an ABDM compliant software. So a piece of software that has been tested with ABDM to make sure that it does this linking part correctly, right? And as far as their day-to-day operations are concerned, we don't expect this to have any significant change or major adoption challenges, because it's largely, if they're already using a software, this is one additional step which is happening under the hood in their software. Now, as I already said, the architecture is designed so that the HIECM itself cannot see any health data. It's data blind. All it sees is who's this user, has a bunch of links to where their health data are, and has a list of consents as to where they have given consents. And finally, not anybody link any information. If you want to link an information, you must be a registered health facility. So only registered medical practitioners or health facilities can link, or you as a user can link your own scanned records in some sense. And that's how the overall architecture works. So I hope that gives you a picture of how we are actually trying to bring the PHR together. Now, for most people who will come on board, this is how the first experience works. Now, let's say you're going to a health facility, and let's make the assumption that this health facility has agreed to participate in ABDM. So you do what you do today, which is you register with your mobile name, date of birth, and gender. Now, if the health facility generates a new digital health record for you, there is a little notification they do. They don't share anything except saying, hey, there is a new health record for this mobile number. They don't share any patient details or health information details. And then you will get a notification which says this facility, so this clinic name is participating in Ayushman Bharat, and if you want to view that record, just click on this link. And if you click on that link, you will actually be given a choice of all the PHR apps. So we have about 5 to 6 organizations that have created PHR apps. Arogya Setu, which is the government's app, and that's being moved from being a track and trace app in the past. In the future, it's going to be a PHR app. So you can choose any of them. So if you already have one, you just click on it. It launches that app. If you do not yet have a PHR address, it will help you create one. And then it will actually discover this record at the health facility and help you view it and also link it. So this is how we expect most of people will start experiencing it. So there is not going to be really like a mass media, but as health facilities come on board, their patients will get educated and they will be able to start collecting health records from those facilities. So this has already started and we are seeing a reasonable traction, and I'll talk a bit more about how this is playing out in the market right now. Now that you have a PHR app, now that you have understood that there is a concept called a PHR app, there is something called a PHR address, the next time you go to your facility, health facility, you will actually be able to simplify your registration. You will find a little QR code that will be stuck at the counter. So very similar to the UPI QR code, you're going to find a little QR code at the registration counter, and you can whip out your PHR app and just scan it, and that will instantly register you. Not only will it register you with the hospital, but it will also help you collect any health records from that hospital. Now, let's say you don't have a PHR app and you're one of those people who have been issued a physical card, you can show that card at the counter, or since these are easy user chosen names, you can also share it verbally and you'll get an OTP and that registration to happen. So we expect this architecture to actually reduce, speed up queues and reduce errors in demographic error, in information being captured at the point of registration, and make sure that if you are clear that you want to collect your health records, there's an easy way for you to do it in the overall system. Now, it's not just about you being able to collect your health records, but that's really, of course, where we want to start. But now suddenly this new benefit comes in. The moment you go scan that little QR code, your facility is able to say, hey, I can see that your PHR address has certain health medical history. They can't see what it is, but they can just tell that, okay, there is certain records linked to it, and they can actually ask for access to that history. So they can actually ask for access to that history. Now, how do they ask for access to that medical history? What they need to do is they need to send something called a consent request. And I'll talk a bit about this in the next slide. But imagine that the health facility is able to create a digital construct saying, I would like access to, say, Sharad's records, and this is what I would like. So it has to have a purpose saying, why do they want to have access? What records do they want? How long they plan to keep it? And they send this into the system, and the patient will get a little pop-up which says, this clinic wants to access your medical history. Do you want to allow? And you can edit, change, control, and say, okay, look, this is what I'm willing to grant as an access to my health records. And not only can you grant it, you have the right to revoke it if you want, and if you decide to change your mind. But the moment you do that, the software at that hospital will now be able to get a copy of your health records, and it can organize it and make sure that by the time you walk in and meet the doctor, you have all of your history organized in front of the doctor. So this is actually how it looks. So the the software at the health facility sends this consent request, it sends it to this public good that we called as the Health Information Exchange and Consent Manager that notifies you on your PHR app. You can then grant the consent, and then when you grant the consent, the Health Information Exchange actually sends this out to all the entities that are holding your health information and says, hey, you've got the consent of the user, now you can share a copy of this with this entity that is seeking these records, and all of this data goes and it does not flow through the Health Information Exchange, but actually flows outside of it. All the records typically flow in an FHIR format, and that ensures that a copy is available to the doctor. And that's really how this works. Now, I just want to share that this is highly aligned. This whole architecture is aligned with what's coming in India in terms of the data privacy laws. So we all know that India's data protection bill is currently in parliament, and it has two constructs, the construct of a data principal and a data fiduciary. It very much applies to healthcare. So any entity, so any hospital or any provider who's creating health data will end up being a data fiduciary. And as a data fiduciary, they will have to offer certain rights to their data principal. And one of the good things is if a hospital decides to adopt ABDM compliant software, we are trying to ensure that they're automatically compliant to the data protection bill. And the consent manager you see, which is part of the bill, and the Health Information Exchange and Consent Manager are very aligned. And while this will evolve once the Data Protection Authority and the final bill and the act is passed, the intent of ABDM was to make sure that it completely aligns its overall system and thinking to India's laws in terms of data privacy that's coming up. So I will just close with this talk on the PHR with a couple of other points. So we have certain terms that we use here. So if you are a hospital and you decide to join ABDM, you become what we call as an health information provider. So an entity that has decided to share health information digitally, you do that. Typically the entity that's holding your health records could be a third party. So you, let's say, using there's a company called Crelio Health. They're a SaaS software that hosts about 1,200 plus labs across India who use them. So they become what we call as a health repository provider. And so the point I'm trying to make is just getting that one Crelio Health to kind of become ABDM compliant means that we can onboard 1,200 labs pretty quickly. And then there is a whole ecosystem of PHR apps. And of course, any entity which wants access to your medical records, as long as you're providing the consent, is able to use it. Now, what the government is going to do is only what you see in the middle in those blocks. So the government is not going to play in terms of any of the other software, and it's really up to the ecosystem to create these compatible software that enables all of these capabilities that we spoke about. Now, how are we looking to get India started on this journey? And I think we spoke about this a bit, but fundamentally, we are looking to onboard as many health facilities as possible. We are trying to make sure that when they create a health record, they either link or notify it with ABDM. And we are also trying to make sure that there is enough consumer choice where patients can view their health records and then they can start sharing it. I'm happy to share with you that there's quite a few people. So we already have enough people who have got their software ready, which will cover more than 2,000 plus labs. We have a target to get over 10,000 plus hospitals and labs live, sharing information in the ABM standards by September of this year. So these are some of the others who are doing integrations. And then here are a whole bunch of players. There is an active ecosystem of people who are trying to become PHR apps, which are on the consumer side when it comes to this ecosystem. And so that journey is on there. Now, as we are we going through this journey, we are finding that India has one challenge which is going to take a certain amount of time to pass through. And that is about not just sharing health information, but sharing health information in a structured data format. Now, almost very, very few systems in India understand or use FHIR. And so when we started interacting with players, we found that there is limited to no use of LOINC or SNOMED-CT or ICD-11 in our Indian software ecosystem. So what we have actually done, and without us moving to structured data, it's going to be very hard for us to do data for public health or even large anonymized data sets that are going to be really useful. And so ABDM is going to try to act as a catalyst to try to move players as they integrate to from being providing unstructured data to more structured data. So we are doing several things and we're giving people time almost up to a year. So what we are allowing people to do today is to say, okay, you have a diagnostic report which is in a PDF format. It's fine, you can start sharing it, but you get 1 year in which you have to actually start sharing a structured version of that. And here are a whole bunch of tools that we can provide for you to make sure that you can quickly adopt and go towards more structured data. And so this is a direction that ABDM is doing, because ABDM has a construct of certification, so we can actually try to push people through that process over time. So while I've spoken a lot about how we will work with personal data, there's a second part of ABDM that's still under construction, so I'm not going to share too much about it, which is the architecture to create aggregated data sets and anonymized data sets. But at a very simple level, think of it as, can we get every lab to share how many HbA1c tests they did in the last month across split by, say, gender, age, and a few other parameters, and how many were outside the normal range? And can we aggregate this in a privacy preserving fashion so that we don't know which lab it is, but we at least know from which geography, so that there is a lot of data that's available for public health use. And that's the kind of direction that we're working on this particular bill. Now, like I said, a lot of what I spoke about was really also was with a smartphone view. And while that's good, because it still is a very large number of users, 500, 600 million users, we have a very clear strategy also on driving this for feature phone and non-phone users, primarily through the government system. And we can talk a bit more about that, Vijay, through the Q&A. I'll move from personal health records to the second part of the mission, which is how are we trying to enable interoperable health claims via health claims exchange. To understand this problem a bit, it's important to look at what really happens in the health claim process today. So if you were to walk into a mid-sized hospital, let's say you go to a Manipal hospital on Airport Road, you'll find a large room called a TPA room. And depending on which insurance that you came in with, you'll find somebody there responding saying, hey, sir, I'll help you more or less. And this is because we have more than 30 plus insurance and TPAs to deal with, and each of them follow a different process for the claim. For some, it requires a form to be filled out, to be scanned and sent over email. For others, there's a form to be filled on a portal that they have provided with a login, and there's still some documents to be scanned and uploaded. And there is still a humongous amount of digitization cost and effort that the TPAs and the insurers do in digitizing the incoming claim, and there 99.99% of claims in India are completely manually adjudicated. We estimated that the cost of a claim in India is over 500 rupees. So if you really are going towards UHC and you're thinking about, I want an OPD claim that includes a consultation and a prescription, this is definitely not something that can be done with the current architecture. So one of the things that we've been doing is we have been trying to reimagine how this should be. And so the way this works is, what we are doing is we are creating a common standard that's called an e-claim standard. So the form that is used for these claims was standardized actually by IRD a long time ago as a paper form. And so now we are coming up with an e-version of that that's called an e-claim form. And we are trying to make that e-claim the same, irrespective of whether it's a government insurance claim or a private insurance claim. So you have to remember that government is a large payer with the Pradhan Mantri Jan Arogya Yojana, with the CGHS, with IISc, and so on. So we are trying to come up with a single standard that can be used. The second thing we are saying is, hey, Mr. Hospital, you can actually create this e-claim using any software that you want. So we hope that the existing HMIS software will actually have a new module built in wherein they can create the e-claim. So that way they don't have to re-enter a lot of data, scan a lot of data. And third, they can submit this claim to a new digital public good that we are creating that's called the Health Claims Exchange. And so once you drop it in, all the Health Claims Exchange does is it's a router. And so it looks at which TPA or insurance company this has to go to. Also, you have to remember that the whole e-claim document is completely encrypted and digitally signed. So the only person who can open it is actually the intended party, which is the insurer or the payer. There is nothing that the Health Claims Exchange can see in the middle, except it can measure certain transaction, but then it now gives you an API through which you can actually track every claim from your pre-auth all the way till your payment. And we think, and in our discussions with the providers and the payers and IRDA actually, we have found that there's a humongous interest in this, because this is one of the key problems that large providers and mid-sized providers are paying, which is the tracking and reconciliation of claims. And this is, we believe, going to simplify it. But there is one beauty, the fact that it's now digital end-to-end will actually mean that we can start applying and payers can start applying better auto adjudication technology. As we know, Western markets like the US, almost up to 90 to 95% of the claims are completely auto adjudicated. And that's going to be very important to bring the cost of the claim down overall in the overall system. So this is the second area that we are working on. There are a few capabilities that we have. I won't spend too much time on it, but imagine that we are not only trying to make the e-claim format digital, we are also trying to make the policy into something called a PML, or a policy markup language, so that you can actually make better decisions on the fly if I had a machine readable policy. Now, this did not really happen overnight. In fact, the regulations for this from IRDA started back in 2016. There was a joint working group that was set up in 20, which recommended the creation of this. And then happy to say that the community came together right through the COVID period. Several large providers, insurers, people, organizations like iSpirit, SWAST Foundation, they've all come together to make sure that there is a common set of specifications for the technology. And I'm happy to share that NHA has taken forward this into the implementation side and will so shortly be launching something called a sandbox, wherein you can actually now raise a claim for PMJAY from any hospital using these APIs. And very shortly, they will also be releasing it for CGHS. And then we are trying to work with IRDA and the insurance ecosystem to make this available for every insurance in the country. Now,
Kiran, it's been about 30 minutes. So just to...
Yeah, about another 10 minutes and I should close. Thanks, Vijay.
Thank you.
Yeah. Running on this, we are not only asking the insurance company to adopt HCX, but we think that PHR also will be powerful, because instead of now scanning and sharing personal health records, you can actually move it through the same architecture to the insurer. I'll cover two other bits that we are working on. You might have heard about the health facility registry as one of the building blocks. One of the things that we are trying to do with that is to actually simplify empanelment. And the idea really here is, can you fill your data once, get it verified once at the facility registry, and then you can share it with anybody who wants it, whether it is an insurance company that you're trying to empanel with, or whether it's for PNDT license being renewed, or for an AERB license being renewed. We are trying to use it to make it actually a tool for providers as an ease of doing business. We are also trying to make sure that there are big MOUs that get signed for every between insurers, TPAs, and hospitals. Can that whole thing also go digital, and we can save some trees? Now, I won't spend too much time on this. I think it's pretty easy to see that this is a win-win-win. We think that HCX will actually bring a win-win-win for all of the parties that are participating in this. The last few portion of my building block slides, Vijay, is about, again, we've spoken about health data, and we have talked about health claims, and the last bit is about health services. And when it comes to health services, we are using a construct that's called open networks. Won't spend too much time on this construct, but except to say that instead of a platform-based approach, where today, if you want, think of it, to get the best telemedicine, teleconsultation experience, you will have to have both the doctor and the patient ideally using the same platform provider and the same end apps. That's when you can have a clean, integrated, good experience. And there is an architectural approach of how you can achieve exactly the same thing using, instead of a common platform, a common protocol, a standardized protocol that is adopted by two parties. So imagine that party one, we call that an end user application, decides to adopt the protocol. Party two, which is a doctor side app, decides to adopt the protocol. As long as both parties agree to adopt the same protocol, you can pretty much achieve exactly the same thing that you would do with a common platform. And that's the core idea. And we are trying to do this for not just teleconsultations, but a whole bunch of services, including ambulance booking, being able to book a physical appointment, booking home lab tests, and so on. And it has several objectives that's powered by these open protocols. A little example here, won't get too much into it, but imagine that you have an end user app on one side. The end user app can actually say, I want to find a doctor. So the doctor now is able to actually choose any app that he wants. He signs in using his health professional ID. He sets up how much he wants to charge for the service. He sets up how much when he's available, and then he can actually be discovered by any of his patients. We think this is very critical because a lot for, if you think of teleconsultations, the repeat and the review consultation is probably the easiest for doctors to move to the teleconsultation than the first consultation. But doctors do not want to promote a particular platform or an app. Now, all they need to do is they need to give away their doctor ID and say, hey, you can use any UHI compatible app. You'll be able to find me on it. You can book my time and let's do this review or let's do this repeat consultation. I'll talk to you in 2 weeks on a teleconsultation. And that's really, we hope, is what will happen with this interoperable teleconsultation flow. So just to finish up, I think we have spoken a lot about what's ABDM. The real question is how it gets started. I have a very nice example I heard Rizwan Quetta use. He says, hey, we are not interested in, if you think about standards like the Bharat stage 4 emission standards, we want you as consumers to understand why you need to buy a BS4 car, but we don't want you to get into the details of how do you make a BS4 car and what the tech specs are. Quite similarly, much of the ABDM magic needs to actually be done by the software provider ecosystem, people who make software for hospitals, labs, anywhere in the healthcare ecosystem. It's their job to get in, understand these APIs, understand how to integrate with these digital public goods and make their software ABDM compliant. So they do this using something we call as the ABDM sandbox. So what we have done is we have taken all of these digital public goods, put a copy of it in the sandbox, and we have said, hey, it's open to anyone, please come in. We are going to support you through this process. We'll give you documentation. We'll tell you how you can actually do this and then integrate, show that you have done the right integration, and then you can exit, and then you can actually start deploying this in production. Happy to share that we have very good participation from the ecosystem. We look at the ecosystem in 3 large groups. We are a focused group that's working with government and government programs. So anybody providing any software to the government, we want to make sure is part of this ecosystem. 2, we are working with organized corporates. We believe that organized corporates are very important because they already have very large IT investments. But the bulk of India's healthcare providers are typically smaller providers, and they will use a software from some vendor who makes a software. So we are also working with the HMIS, LMIS players to make their software compliant. And you should see, and we hope that within the next 1 to 2 years, you will start seeing ABDM start to touch all of our lives as these solutions start to go live nationally. And that's the end of my talk. So thank you so much. And I think back to you, Vijay.
Thank you, Kiran. Of course, for many in the audience, I do believe that this was a little bit of a quick but extensive overview, and I think a little bit of the MIT euphemism of drinking from a fire hose, right? So I think maybe in the discussion now we will try to get a little more clarity on what all this actually means. And maybe just to start things off, I'd like to go to Dr. Sharada Iyengar. And Doctor, can you first make some comments and perhaps have a question or a question or two for Kiran to elaborate some of the details of how this all plays out in actual community health practice, and then we can. I'll do the same with Sharad Sharma, and then we can come back to Kiran for his responses. So, Dr. Iyengar, please.
Thank you very much, and a big thanks for inviting me and giving me an opportunity to participate and to also bring the perspective of the bottom of the pyramid. I must say, this is not just an impressive presentation for its own sake, but it's impressive because of the range and the scope, the sweep that it seeks to cover. in phases. So, I mean, I must commend Kiran and all the colleagues who have made this possible, and also wish it well. I think essentially the idea of a universal health interface is extremely exciting. We know about the universal payments interface. It's one of those unique things where India seems to be, really pioneering a way in getting, technology as a public good right across people. And I hope that UHI would also go the same way. I don't know whether this is my own thinking, but I can clearly see that in moving from a platform-based protocol to a network-based protocol, there is, everyone in a sense compelled by the system and by the environment to hook up to a network which, has been presented as a public good. You are achieving a certain level of decommercialization of this whole system. And I think it's decommercialization for the good, in that people, yes, can in a way make their apps and make their software, but essentially the central core remains as a public good, and therefore reduces chances of very strong imbalances in costs, in effort, and to put it frankly, in the healthcare sector, it being full of that, reducing the chances of exploitation. I find, Kiran, that, and this is the first response, I do wish to talk of other things pertaining to the bottom of the pyramid later. I find that this system would work best in a hospital and a hospital-linked setting, which is a good way to begin. The urban scenario, the middle class provider who needs help and assistance in accessing healthcare may or may not be insured. Healthcare is often very disorganized for such people. People go around seeking healthcare when they have to, and they simply have to. There is a phase of denial, there's a phase of neglect for several conditions. There is quite obviously an inability to go around making lifestyle changes or preventing diseases and conditions from increasing and worsening. And in such a situation, something that organizes their healthcare seeking in a better manner would be useful. So what I can see is that this is a system that would begin well in cities, even go down to towns, and would rotate around a health system, an ecosystem of formal healthcare provision by doctors, clinics, and large hospitals, with downstream links to people like therapists and other facilities, which automatically link to hospitals, especially after hospitalization. Some thoughts on your conversations or a dialogue on where does the public health system come in? Because when we talk of primary healthcare, essentially primary healthcare is not primary medical care. I mean, this is an oft-repeated error that people think that there is medicine right out in the periphery. Well, it takes a form of healthcare, which takes a form of things which are not so very clinical, not so very medication oriented, not so very investigation oriented. And yet that is the phase at which ideally people should be interacting with the health system first before running to a hospital because something went terribly wrong. So I didn't see that to the extent that I would have liked to. An interface with primary healthcare, the systems for primary healthcare, I know they are not all that strong in peripheral areas, in rural areas. How do you see this going there? And I'm saying this acknowledging that this is a great beginning, but in anticipating a move towards primary care, which will link to secondary care, how do you see that?
Thank you, Dr. Iyengar. I think, as I said, maybe we'll first take some remarks and also maybe some queries for Kiran from Sharad. I think Sharad, there's obviously a larger vision behind the India Health Stack. I think ABDM is starting to implement some parts of that. Perhaps you can lay out some of the bigger vision and also zero in on some discussion item for the panel. Right. Thank you. Good.
Yeah. Thanks, Vijay. So clearly, I mean, the first hypothesis that is there is that if the flow of people, the flow of information, flow of money can be streamlined, many existing things that are happening will improve a lot, right? And Actually, vaccination has been an illustration of that. And what we have seen Kiran describe is that flow of people through the ABA ID, flow of information through PHR, flow of money through the health claims exchange. And there are other things, in that bucket that are coming like e-rupee, which are all to streamline these three items so that people, players, individuals, systems in the health sector, they can reduce friction and they can actually do things better than what they were doing before. But by itself, that will not improve the health system substantially, right? We have enormous access problems. On one side, we have medical tourism, for people who are coming from the outside. On the other end, we have hundreds and hundreds of millions of people who don't have access to basic healthcare, right? So we have that duality to deal with. We have this whole issue of state failure and market failure to deal with, right? I mean, there are many places where we have state failure in delivery of health services. And of course, there are numerous areas often highlighted by what has happened in COVID of market failures that have taken place as well. So the list of things that we have to tackle are large as we go forward. As Dr. Iyengar mentioned, some of these technology and techno-legal interventions can help things happen. And I would merely say that we are at the very start of a long journey of making a real impact, on the ground for having healthier Indians over time.
Thanks, Sharath. And I think maybe I'll pass it on to Kiran to maybe make some additional remarks, particularly responding to Dr. Iyengar's
No, I think, thank you so much, Vijay. And I think you're absolutely right, Dr. Sharath. I think primary care in India is still very challenging. I'll tell you a few things that ABDM is doing. So you might, at least on the government side, as you know, government is also still a significant provider of primary care. And one of the things it's trying, the way it does it is through either its new health and wellness center initiative or through many public health programs, whether it's the mother and child program, the Nikshay program, the including Pradhan Mantri Jan Arogya Yojana and so on. Not so much in primary care, but much more in secondary care in that case. One of the challenges even in that has been that health information has never flown or been aggregated in the construct of even the government, so that it can be actually used in the continuum of care. So what ABDM is starting to focus on is first say that every program should identify users in the same common methodology, and every program must share health information with the patient. Now you must remember that health information was available to administrators. If you are somebody who works in, say, you're the principal secretary health, you can probably get data on, how many births happened, by which location, how many maternal deaths happened, but there isn't really, for example, if you seek ANCs with an ANM and then decide to, with the government ANM and then decide to go to private care further, there isn't any data that is flowing with you as you go from this public to private or back, which is in the hands of the patient. And so what ABDM will change for the patient is first this. It will ensure that every government program which is creating data will be able to share the data with the patient. And then as patients, the architecture enables them to take control, whether they're going in public or in private, to be able to use their data for their better treatment. And that's really where I think we are starting. Now, data, of course, as we know, is also likely to be the one that leads to, transparency, as they say, can bring a big change in many things. And we hope that as we enable what we call, Sharad and me call this the plumbing for data, as we make this plumbing layer come to life, we think that will then trigger many other improvements as we kind of go along. And like I shared with you, we are making sure that this works for both people from the top of the pyramid and bottom of the pyramid. There is a very good question in the Q&A on consent and how consent works for the bottom of the pyramid, I must tell you that this is one of the key areas that we are still piloting and trying to learn. Informed consent, and even the consent that we recognize here within ABDM, we do believe must come with certain safeguards in the beginning, especially for people who are either using feature phones or no phones, because they will be providing access to their data on more or less a standardized templated consent. And then we will need to understand what are the easiest ways for them to provide that consent. Today, we see that using some kind of an OTP as well as a biometric method. But more important, how do we educate them on what exactly did they provide consent for? I think that's where much of the learning is, because there isn't really an interface that we are providing for them saying, hey, look, this is what you can give. So that's something that we think will evolve. But we are big believers that ABDM will make a difference in primary care. A second area that I just want to bring in is there's always this talk about how do we go from a curative kind of a centric mode towards a more wellness centric mode. And so, Sharad and me have spoken in the past about certain incentives that now a digital infrastructure like ABDM can help create. So let's start, for example, with the Pradhan Mantri Jan Arogya Yojana, PMJY, right? Now, we know that PMJY is paying for, say, cardiac cases. We know how many cardiac cases we are paying for. We also know that through the government's NCD program and other programs, we are starting to do large screening for people who are hypertensive or diabetics. Now, to me, if I knew the cohort of people who were, and if I knew their biomarkers saying there is a probability that these people are likely to end up, making a claim in the future under a cardiac care, it actually provides a financial incentive for me to say, can we identify intermediaries who, given a cohort of these people, can help change their behavior so that their biomarkers improve? So that, and all of those activities, if you think of what that entity will have to do, will have to be in the preventive side. So we think that data layers like this can actually make a shift in how we operate as a country, but we don't have the technology layer to make that happen today. I mean, I think this is where we think we want the health stack to go, but not something that can happen overnight.
So thank you, Kiran, and I wanted to bring up a question that came up in the chat, and we'll go to more open sort of Q&A with the audience. But one quick sort of question was, how many people have actually signed up for ABBA, and where are those numbers today? And
yeah, so there's a site, you can actually look them up, Vijay. It's public. There's called dashboard.abdm.gov.in, but over, I think last I checked, it was over close to 15 crore people. I think the number of ABBAs themselves are irrelevant in my mind. Sure. I look at the actual number of health records being linked, shared, and then access, because ABBA is just the ABBA address is more like I have an email ID, but if I don't use it, it's of really limited value.
Okay. The other question I wanted to bring up was, we've often had this discussion within the Lancet Commission, Citizens Commission, that in some sense, health workers, and and I'm talking about community health workers, even ASHAs and ANMs and so on, that information flow is always away from them, right? So they are expected to collect information and then send it upwards, right? Is there mechanisms now with ABDM for information to actually flow back to them and empower them in some ways? Right?
I mean, the system, like I described to you, the fact that here's what we are trying to do, right? So what we're trying to do is, first we are trying to make sure that if you are a government health program, at least right now, you must start sharing information with the patient, which does not happen today. I mean, if you look across the programs, very few government health programs actually, they collect the data, they create the data, they don't actually share it back with the patient. So we are actually pushing every program to do that. Second, what we're saying is that if you are a healthcare provider in the government, whether you're an ANM or an ASHA worker, we are coming up with a process by which they can actually now access the data that's there in front of the patient that they are. And we are trying to make sure that systems start, and this is going to be an evolution, Vijay, because it will take some time for systems to then say, okay, now that I have access to this patient's data, how do I use it for better treatment in the context of whatever service I'm now trying to provide to you? But I think we are providing the plumbing to enable that particular thing to happen.
Right. Okay. Fair enough. I think I have a quick question for Sharad Sharma. I think Sharad, I think there is a perceived danger around this kind of digital infrastructure. Will it lead to excess privatization, transactionalized services, undercut public health? And would you care to sort of respond to those kinds of fears, right?
Yeah. So I think if traditionally, digitalization has created winner take all kind of scenarios where the power has shifted to digital intermediaries who are not necessarily working in the interest of either party, right? I mean, so classic example, of course, is that you could have a Swiggy or a Uber where where Uber is neither working for the rider nor working for the driver. They're working for themselves, right? And the traditional approach to digitalization has made these kind of intermediaries who are a law into themselves, very powerful at the cost of every other party. Now, that is a danger that exists, because that has been the situation for digitization everywhere else in the world. In India, I think we've taken a approach because we came into digitization a little later with the benefit of, with the hindsight, with having the ability to look at what had happened in other places. There is an attempt to deal with it at the root itself. So when Kiran talked about the open network, which Dr. Iyengar talked about, instead of putting a company in the middle as an intermediary, putting a protocol in the middle is a very important concept. And the second, related concept that you have here is that either you represent the patient or you represent the provider. No, you can't represent both, because when you represent both, you actually represent neither, right? So essentially, therefore having fiduciary responsibilities, right? And in some cases, I think India is standing out and getting attention of the world because in many sectors, we have managed to do this well. Some of you may know we are doing this well, for example, even in the financial sector, which with brokers versus registered investment advisors, right? We are the first country in the world to have more mutual fund investments happen, and mutual fund investments are very often by very small savers, happen through registered investment advisors who are only the agents of the saver. They're not the agents of the mutual fund, right? Versus distributors who will claim to do the right thing for you, but actually will do what the distribution fee asks them to do. We've done that in cable television. We've done that in the payment system, right? So this is happening right now in lending with something called Open Credit Enablement Network. And so there is an organized effort in the country to make sure that we don't create these digital intermediaries, right? Who actually work only for themselves, neither for the patient nor for the provider. So we have to make sure that we bring this to life. I think this is, Kiran would attest to it, that this is a very deep conversation that is taking place both in the health ministry as well as in NHA to make sure that you capture every learning that has taken place so far, and not fall for the trap that has been the case for almost every other health system in the world.
Right. So Kiran, I think something that Sharad just mentioned, I think, could you just clarify a little bit on how ABDM relates to NHA, PMJ, NHM, Ministry of Health, because I think there seems to be a number of agencies involved, and just
I
to
think,
clarify, right? Yeah.
yeah, thanks.
Yeah.
So the National Health Authority is essentially an attached office of the Ministry of Health and Family Welfare. So the Ministry of Health and Family Welfare is, of course, the larger body that oversees most of the government's healthcare initiatives. Uh, the National Health Authority just has two programs that it is an implementing agency for. The first is the Pradhana Mantri Jan Arogya Yojana, which is the 5 lakh rupees of health insurance for covering for 500 million people below the poverty line. And so that's one program. And the second is the Ayushman Bharat Digital Mission, which is what I kind of presented today. So they have these two things as implementation responsibility. So they get an annual budget to actually kind of run these programs, build and operate these digital public goods, and try to get ecosystem adoption for these digital public goods. The most of the programs like that we call as under the National Health Mission, whether it is the mother and child program, are all under MOHFW, including the primary care initiative of the government of India, which is called Ayushman Bharat Health and Wellness Center, is not managed by NHA. It's actually managed directly by MOHFW in some sense.
Thank you. And maybe for the last sort of in-panel discussion item, I'm going to request Dr. Sharada Iyengar to maybe talk about some of the attempts at digitization that has happened at the community, health level, and where you have run into challenges, and whether, and then we can see whether, somehow ABDM helps, address some of those challenges. So some comments from your side. Yeah.
Thank you, Vijay. In a way, digital infrastructure and technology can either help to make primary care and access for the bottom of the pyramid easier, but if driven in a certain manner, the exact opposite could occur. So, Sharad, you spoke of intermediaries. There are intermediaries even within the health system. They act like brokers for purveying healthcare, often taking a very high commission. And it's possible that a good digital system will be able to reduce that. Let me give you a few examples. The bulk of my work is in the area of sexual and reproductive health. Most of it tries to reach out to women, often young women who are struggling in the early phase of their lives, because that's when sexual and reproductive health issues are the most important. There are issues of choice, decision-making, the giving of rights or the denial of rights. There can be domestic violence, contraception, abortion, and, related issues like infections. Genital tract infections are very secret, very confidential. It doesn't help to go around that your husband or your partner or some relative has a phone that you could share. You cannot share this information. So it's not digital or otherwise. These are the areas that, in a way, land up going to the health underworld. But I do still feel that the digital route can help. What we need is to try and see that, certain steps are taken. The world of healthcare itself suffers from a lot of over-medicalization. I'm sure all of you at some point have encountered unnecessary investigations, very elaborate treatment protocols, and in effect, a lot of costs go around treating something that could be treated in a simpler manner. Within primary care, this is happening. What we need is demedicalization, a way to reduce a lot of this. And if there are those protocols and standardization that you have mentioned in the strategy document of ABDM, that is a second layer of issues that you plan to take up. I think a lot of good would be done to help us along with demedicalization. And that's where some of the pilot experiments with digitization have taken place. In a bid to see that non-physicians, especially nurse midwives, community health workers, and others can use digital technology to take decisions on the spot. And often these decisions are very simple. You try and treat A, B, and C of the patient's condition. If it is D, you make a referral to a higher level of care. But most of the time, it is an A, B, or C which they can treat themselves. You have a digital system that offers decision-making support. You also have decision-making systems which allow, which give advice on how to refer. So we have used apps which tell a person when to refer and then support the referral process. Now, referral, especially in an emergency, is a time where, for example, the ABDM Act might have to allow access to records without consent. If somebody is bleeding to death, you don't go around telling them to give consent to see their records. So I'm sure some exceptions will be put into the system. The other is that a lot of the care for chronic conditions will involve some amount of hospital care for a diagnosis and investigations, but a lot of simple diagnosis and treatment and advice and lifestyle changes at a peripheral level. To treat a chronic condition, to treat an older person, the kind of things that a health and wellness center is meant to be taking up. In order to reduce costs to the health system, we'll have to see that a lot of care moves into the periphery, either moves into a small facility or into the community or even a home. And using point of care devices, you can visualize having outreach workers who can be equipped with digital software. We've done some of this. Now, the challenge that we have seen in doing this is that while it is fairly simple to go around training your community health workers to use a technology platform, it, for example, needs to be in the local language. I have been wondering about, how languages will change in this system that you are visualizing. Is it all going to be in English and Hindi, or which language? People are comfortable in the language of their state, and occasionally a state may have even 2 languages or more. There is the aspect within this care of seeing that data moves seamlessly from home care to hospital care and back to home care. Otherwise, see what happens to people who've suffered stroke or a heart attack or after, say, cancer chemotherapy or surgery. They keep queuing back at hospitals every 1 month or 2 months at extremely high cost and inconvenience. If some of that care could be pushed out into the periphery, it would be helpful, but you need a data system that bridges these 2 levels. The primary care system, the home, as well as the hospital. So I think it's very important that ABDM takes up this challenge of integrating these 2 levels of care. It is there in the genes of ABDM from what I have been hearing from you, Kiran. The third aspect is we're going to have, especially in the government system, but even otherwise, a lot of informal healthcare. You have practicing doctors, practicing paramedics within the government system. It's allowed in some states or many states of the country. And it is just possible that those who are providing informal care or doing the private practice side of their government appointee care may not want to record it in a digital platform. So there could be accountability issues coming up. And the third and last thing I wish to mention is this huge challenge that every government, every state, every district faces, but is not willing to speak out in meetings about, is that you are not assured that your frontline workers are there out in the on the front lines. You have a lot of truancy in places with the greatest dysfunctionality in the interior forests of Chhattisgarh and Bastar and so on, or even in hilly and tribal areas where there are high levels of poverty. You find that outreach workers are not reaching out. And I think there is scope for a digital platform to basically track person, time, and place using locational determination to make sure that when people say that they are visiting a home or visiting a village and providing care, they indeed are doing that. Now, certainly there's going to be a pushback from a system which has not been used to this kind of scrutiny. It's going to be seen as policing. It's going to be seen as, someone, Big Brother is watching you. But seriously, those of us who work in organizations, most of us go punch attendance. We are seen, we are heard, we are present. And I think we need to ensure that in some of these peripheral areas, it's not being touched upon because basically you're looking at the patient level of care. Otherwise, what we have is ghost workers, ghost services, and ghost reports, which have very low credibility. So I wanted to touch on a few of these issues, and I'll end with this last aspect, which I see in a lot of laws which govern and rules and regulations governing things like abortion, things like drug usage, and even pollution control that affect health services, which is that there seems to be in the doing one set of rules for government institutions and another set of rules for the private institutions. Now, without going into demonizing any private institution or setup, we have a mixed health economy. I think we should be careful that ABDM and all that is associated with it and the laws and regulations, hopefully, have the same registration and data access requirements and privileges to government facilities as well as private facilities. It's not that the private facilities have to do a longer slog to reach that same point. So I do feel that while in the private sector, in the public health sector, state governments have adopted a whole manner of softwares. We have something for the Ashas called Asha Soft, and we have something else which other health workers use. There are vertical softwares. It's going to be a challenge for you to integrate them into an ABDM as you move ABDM to start interfacing with primary healthcare. But given that the control of chronic conditions is going to involve facility care and community care, I think there is no choice. At some stage, fairly early, we'll have to start grappling with these granular issues.
Thank you. Thank you, Dr. Iyengar. I think, very, very insightful comments. And I think hopefully, we will see, some aspects being addressed as ABDM develops. I want to now give some time to the audience for their questions. So maybe we get about 10 minutes to do that. And let me start out with one very simple question that has come up, which is who owns and controls the personal health records, the PHRs? Is there, a crisp answer to that, Kiran? Right?
Yeah, even Sharad can take that, I think.
Okay,
Yes,
sure.
Yeah, see, in terms of, I think, and maybe Sharad, you wanna take this one?
No, I'll just give the basic principle that the India, I think, is taken with the PDP bill also. It's also happened in financial data. The health data is owned by the patient. It is patient's data. It is in some sense because it's created by the provider and the patient interaction. Strictly speaking, there is co-ownership between the two. And, but, you cannot share it with a third party unless both parties agree. So essentially what the PHR system does, in the past, what could happen is you could share this data with somebody if the hospital agreed to share the data. But now you can't do it because the patient has to also agree. And if the patient wants it to be shared, they can do it they can download it, they can put it in DigiLocker, they can do all of that. But if they want the hospital to do it, in effect, the hospital is also agreeing to do this. So the way the system is working is that it is really the patient is being brought into the loop for what happens with their data in a way that has never been the case before. And therefore, they will play a very important role as we go forward. Right, Kiran? Is that fair?
Absolutely. Very well put, Sharad. And I just want to add what some of the queries are and what Dr. Sharad also brought up. One of the things that we're trying to do, Vijay, is to try to make sure that when healthcare providers link data, and we're also trying to identify classes of data, to mark them as being sensitive, so that in the process of sharing, so classic examples, HIV, abortions, there are mental health issues. So we want to make sure that from a user perspective, they can, they're going for a fever, maybe they don't want to share certain things. What you need to realize is the architecture allows the user to decide what to share and what not to share. And we want to make it simpler and simpler for users to make that decision. Now, it could be argued, if you really put on a healthcare provider's hat, the healthcare provider will say, hey, I need to have the right to see everything. Otherwise, I can't make the right prescription or I can't do the right diagnosis and so on. But I think that is for our society to evolve. We are doing what at least the current laws of user control and user being in the right says in terms of the current situation.
Thank you. Yeah, I think that's enlightened and hopefully does eventually empower citizens. And I think our commission is all about the citizens' control over their healthcare, of course. I think there's a slightly interesting question. This particularly to Sharad Sharma and to you, Kiran. I think health technology implementation without involving doctors, patients, etc., has failed even in the developing countries, right, and in advanced countries. But and most of the on-ground physicians, providers, health staff see this as an administrative headache, and so are we creating a white elephant, or how do you respond to that? Maybe Sharad, you have an answer there too.
Yeah, so see, I think based on the plumbing, many parties are being brought into a digital system, the labs, the hospitals. Hospitals will come in because the health claims engine will make their life easier. Labs will come in because of the PHR itself, and so on and so forth. But it is very important that we bring in the first line medical practitioners, right? The doctors, or I would even say the Ayush doctors into the system. And it is very important that we do it in the right way, and which is to empower them, enable them, especially the good doctors, to be more effective than what would they have been in the past. Now, I go back to what you had pointed out a little earlier. There is an alternate way of doing it as well. The alternate way is to sell, market to the patients, and make this e-commerce based kind of a solution, right? And we know when that happens, we get very bad outcomes, right? And so we have to make sure the system builds itself out by now, enrolling the doctors. More of them become part of the system with the health professional registry. There is a system where they feel that the digitization is working for them to effect or enable to be able to deliver better care to their patients than would have been the case otherwise. These are all steps that are going to be very important in the next couple of years. And, I think the intent is to go down this path of enabling the doctors to deliver better care to their patients, and not fall, to the e-commerce trap that we talked about a little earlier, the Swiggy, Uber, trap where market pitches are made and acquisition costs are talked about, and so on and so forth. So this is a fork in the road that we have. I think we've chosen the right fork, and now 2 years later, we will know whether we have implemented it well or not. This is something that will take time to show up. Right, Kiran? Is there anything you would like to add to that?
To that extent, I think ABDM would have first mover advantage, but ultimately we should now try and see that people like Ashas and nurses and such people are able to enroll as providers. So long as you restrict providers to doctors, you're going to stay with secondary care and hospital care. We need to move out. It can come at a later stage, but it needs to be thought of right now.
Very well.
Yeah. So, one sort of technical question, I guess, that came up in Dr. Iyengar's comments is language, right? And so how is ABDM looking at the whole issue of localized sort of language content communication, and or is it all being centered around English and or maybe Hindi? But Kiran, is there a perspective on this? Right.
I mean, at least to my experience, yeah, most of the health records I have come across so far are all in English. I have not seen. I know that there are attempts, for example, on prescriptions. I know that the national NRCES, which is the National Resource Center for E-Health Standards, has given prescription formats in multiple languages. I think they now cover about 6 languages, so that prescriptions, when printed, can be in a local language. But at least in terms of at least my experience or exposure so far, I am still not seeing enough, I would say, localization on this particular.
Yeah, but does the framework allow for
we are agnostic,
technologies to be brought in?
Absolutely agnostic to language, and we would love to see whatever the local needs are. I think that will be the best.
And these would come through the UHIs, or how would these languages?
The health data itself, so the software that is used to create health data will need to essentially evolve to be multilingual, so to speak.
Right. I think maybe we can take one more question and then we'll probably have to wrap up. Is there any pressing question that I've missed that one of you has seen?
There's one that I wanted to talk a bit about on the adoption strategy and incentives. I think one of the things that we didn't talk too much about, Vijay, is that at this time ABDM there is no legal drive that providers must adopt ABDM, right? So they can continue the way they are, and they decide, okay, I don't want to be part of this ecosystem, and that's quite possible. And so one of the things that is very important for our ABDM's adoption is to find key use cases that provide benefit to both providers as well as consumers, so that the adoption cycle can really start. And so one of the things that NHA is trying to work with the ecosystem is to identify what are these use cases that will have certain traction in the market so that can accelerate ABDM adoption. It is challenging, I must say, given where things are. The second thing is the government is now starting to mull. If you look at what happened in the US, to get every GP to start using software, they spent, I think, close to $40+ billion in as part of the Obamacare packages, right? So there is certain thought process already starting as to whether there needs to be financial incentives in India to be able to do that. So hopefully we will see some amount of both coming, what kind of strong use cases as well as certain financial incentives for adoption. But I would say, Sharad has this very nice view, and he can take you through this timeline for what happened with UPI. We all celebrate the success of UPI today, but you should know that the specifications for UPI were written back in 2015, Sharad? First implementations in 2016. Sharad can promise you that I've never seen those apps, but he says the very first people who implemented the UPI standards were absolutely unusable. And then it really took till 2018 to have something that had good consumer traction, and 2019 really for the takeoff. Did I get that timeline right, Sharad?
Yeah, that these are, we have to be patient. We have to do the right things. There's a lot of cleanup that is required in the beginning. Many of our commenters and questioners are saying, hey, will we get this right? And I just want to tell you that there's no immaculate conception. I think if the principles are right, and there is always going to be tinkering and improvements that will have to be done to get to scale, and nothing is guaranteed here. Failures abound in this area. So there's a lot of work to do, and I think, everybody who's pointing out where their pitfalls are, that is very, very useful, because there are many pitfalls along the way before we get to, truly India scale here.
So thank you very much. I think, this was sort of the technology workstream webinar from the Lancet Citizens Commission's series. And Sharad Sharma and I co-chair the technology workstream. And I think for our webinar, we were very clear that, it would be important to focus on ABDM and bring out, exactly what it is about, and try to bring some clarity around that to all the stakeholders, and of course, most importantly, to the perspectives around sort of a citizen-centered view of getting to universal healthcare. So I'd like to thank the panelists. I think Kiran in particular for sort of giving us such a detailed view of how it's being built. What are the different building blocks. Whether it is on the the personal health records, the exchanges for claims, and then finally so the payer perspectives, and then of course how health services will be rolled out through this infrastructure. I'd like to thank, of course, Sharad Sharma, for also bringing some clarity on the larger sort of architecture issues, and I would particularly like to thank Dr. Iyengar, because I think he brought perspectives, I guess, from the community health side, and also from how all of this could impact, and both from the perspective of what remains probably aspects of the infrastructure that needs to be laid out, and also some of the challenges that we actually have some opportunity with this public goods approach, which actually can alleviate some of the challenges that health systems have been plagued with. So in India particularly. So I think we're at the hour. So I'd like to thank everyone and thank the many participants who came on. I'm afraid we may not have addressed all of the questions. We'll record them and perhaps get responses to those who have provided contact, or maybe we'll find some way to put up something on the website of the commission, which would be responses to some of the questions that have come up. Maybe I'll request Kiran to maybe take a look once we compile the whole list and send it across. And, thank you. Yeah, thank you. So thank you all, and I'll hand it back now to Pooja and to let us know what
Thanks, Vijay.
should be done. Yeah, thank you.
Thank you.